A warm welcome to everyone to the anesthesia class. The topic that we are going to study today is airway management or the airway equipments. The importance of this topic lies in the fact that this topic compromises of a lot of image-based questions that have become a trend of the NEET PG exams. So starting with the airway equipments and the management part, before that, let's have a quick recap of the natural airway. So your natural airway is nothing but the passage through which the air enters our lung. It comprises of nasopharynx, oro and laryngopharynx. The thing that is very important for you all to understand is the concept of dead space. See, when we talk about the dead space, it is nothing but the areas. Dead space is an area which is ventilated, but it does not have any perfusion. I repeat, dead space is those areas which are ventilated, which have air in it, but there is no perfusion and thus there is no exchange. That is why it is known as dead space. And vice versa is your shunt. Shunt is those areas where perfusion is present, but there is lack of oxygenation in those areas. Those areas form the shunt. When we talk about a dead space, we have anatomic dead space, physiological dead spaces, plus your mechanical dead space. Your anatomic dead space is like your passage, the air passage from your nasopharynx or the oropharynx till your terminal bronchioles, which are the conducting zone where there is air, but there is no perfusion for the exchange to take place. Generally, the anatomic dead space is nothing but 150 to 200 ml. Then you have alveolar dead space. The alveolar dead space are those ventilated areas in the lungs which do not have blood flow. Some parts of this could be physiological in nature also. But yes, when it exceeds, then it could be pathological dead space which is present. The mechanical dead space is nothing but the artificial airway, like your breathing circuits, your face mask. All this gives a dead space, and that the volume of those breathing circuits form a dead space because they have that oxygen in it, but they don't have any perfusion for the exchange to occur. This forms the total dead space: your anatomic dead space, alveolar dead space, and your mechanical dead space. Now, there are certain maneuvers which lead to increase or decrease in this dead space. This is what you all have to remember because this is asked. The triple maneuver, which is the head tilt, chin lift, the jaw thrust. If you remember that from the CPR class, all this increases the dead space. Then the mechanical ventilation, because of the presence of the breathing circuits, will increase the dead space. Atropine and salbutamol are going to lead to dilation, which is eventually going to increase the volume of the dead space, right? Now, what decreases the dead space? The ET tube, the definitive airway that we form, it decreases the dead space, plus your tracheostomy. These two are going to decrease the dead space because the volume of your endotracheal tube is lesser than what is your natural airway passage volume. Coming to the tracheobronchial tree. This is the Wibbles classification, and you all have to remember this classification because according to this classification, the tracheobronchial tree is divided into 23 generations. Please remember, you have 23 generations, out of which 0 to 17 is only the conducting zone, starting from the trachea to the terminal bronchiole. Here you can see from the trachea to the terminal bronchiole, we just have the conducting zone where there is no exchange of gases that are occurring. Then from the 17 to 23, we have the respiratory zone where actually the exchange of the gases takes place. The whole of the tracheobronchial tree can be divided into, from trachea comes your left and the right bronchus. Please remember that in adults, the right and the left bronchus are not at the same angle. The right bronchus is wider, shorter, and in straight line, that is around 25-degree angle it forms, whereas the left bronchus forms an angle of 45 degree in adults, whereas when we talk about the pediatric cases, it's almost the same, 55 degrees and 55 degrees. That is the main reason why The incidence of endobronchial intubation, if we are talking about the intubation, the tendency of the endotracheal tube is always to go towards the right side because it is shorter, wider, and more in line with your main trachea. From the bronchus, we get the bronchioles, the terminal bronchioles, the respiratory bronchioles, from which we get the alveolar ducts, which eventually lead to the one alveolar sac, which is the area where the exchange of the gases start taking place. Then your lungs are divided into various lobes, and the lobes are divided into the bronchopulmonary segments, which I hope is cleared in the physiology or the anatomical parts. But you all have to remember this anatomy of the tracheobronchial tree. Moving with the real part of the class, that are the artificial airways. See, artificial airway, depending upon where it rests, it can be supraglottic. As the name suggests, it will be above the glottic opening. Glottis is your vocal cords. Okay. Above the glottic is supraglottic, which could be your airways like nasopharyngeal, oropharyngeal airways. It could be your face mask, or it could be your supraglottic airway devices. Infraglottic, those airway devices which go beyond your glottis. They are below your vocal cords. This could be your endotracheal intubation, which could be oral or nasal. Then comes surgical airway. It could be tracheostomy or cricothyrotomies. Now talking one by one about the airway equipments. I've already told you this is more of an image based class. So please look at the images very carefully, because generally most of the images of anesthesia come from this airway equipment part. These are your anatomical airways or anatomical face masks. Actually, this is the adult size and this is the pediatric. This is for child. And these masks are also known as Rendell-Shocker-Baker masks. These can be of various types depending upon, it can be form of silicone, it can be made of plastics, it can be made up of rubber. They are present in different sizes ranging from 00 to 5. The advantage of this mask is, because generally the advantages and disadvantages of various airway equipments is asked. Of course, what this mask does is, this mask helps us in giving oxygen to the patient. It helps in ventilating the patient. It also helps in giving positive pressure ventilation to the patient till we can have a definitive airway to the patient. If you remember from the CPR or the BLS class, these masks were used for head tilt, chin lift maneuvers, and these masks were kept, and with the help of the ambu bag or with the help of the breathing circuits, we can oxygenate the patient via these masks. Now the star or the most important part of these masks is the dead space. Whether the dead space is increased or decreased, the dead space is increased in the mask. And what is the dead space of the mask? It is this area. This whole area of the mask forms the dead space, because if you can imagine, this is the area which is filled with the air, with the gas. But there is no blood vessels. So this forms the dead space of the mask. And this can be calculated how? This is equal to the volume of this mask. The advantages of this mask is, as it does not require any airway manipulation, so there are no chances of any sore throat. Anesthetic depth has to be less. No muscle relaxation is required if you are putting this mask, only this mask, over the face of the patient in order to provide him or her with oxygen. It is quite cost efficient because these are reusable in nature. The disadvantages of these masks is, if you can see, your hands are engaged when you are holding this mask. Of course, this is inefficient way. It is just to buy time in the form of pre-oxygenation during general anesthesia, or it is to buy time till your definitive airway has been secured. The dead space increases. It's not a foolproof method. It does not prevent aspiration. Rather, it can lead to increase in the work of breathing, especially in a spontaneously breathing patient. Plus, When you are giving positive pressure ventilation via these masks to the patient, of course, your trachea and esophagus are quite near to each other, right? I hope you understand that. So, air is also going to get inside your esophagus, leading to gastric distension, which can eventually lead to aspiration chances increased. So, those are the disadvantages of using these masks. Complications of this mask, it can lead to skin problems because the mask is put on the face like this. Okay, so it can lead to dermatitis if you're allergic to the material from which the mask has been made. It can lead to nerve injury because of constant pressure of the mask on the face. Actually, it forms a seal. The tip of the mask is kept on the tip of the nose and it forms a seal around your cheeks till your mentum. Foreign body aspiration could be there, gastric insufflation leading to pulmonary aspiration. Corneal abrasion has been seen because of the bad technique of using these masks. Then, yes, latex. Many a time these masks are made up of rubber or latex, which the person can be allergic to. The jaw pain can be there, the dead space increases. This is the right time to discuss one thing with you. Again, a star mark question. I already told these masks are used for one thing. They are used for pre-oxygenation. See, when we talk about pre-oxygenation, many questions are asked on pre-oxygenation. See, pre-oxygenation first, what is the goal of pre-oxygenation? This is to give FiO2 of 100% to the patient in order to fill the FRC of the patient whole with oxygen. The functional residual capacity has to be oxygenated. It has to be full of oxygen so that we can buy the apneic time, the time we take for intubation when the person is not being ventilated or the person is under the effect of muscle relaxants and the person is not having any breaths of its own, and we are also not providing any positive pressure ventilation because we are intubating that patient. So we have to buy that apneic time, for which we have to pre-oxygenate the patient such that the whole lungs are filled with oxygen. That is, the FRC is filled with oxygen. That is the goal of pre-oxygenation. We have to take out all the N2, the nitrogen, out of our body. We have to denitrogenate our lungs. That is the goal. Second is, how can we pre-oxygenate the patient using these face masks? There are two steps. First is a 3-minute pre-oxygenation via FiO2 100%, giving tidal volumes. The patient is asked to spontaneously breathe normally, and this is done for 3 minutes. Or the second is by giving 8 vital capacity breaths in 1 minute, or sometimes in the options it is written like 4 vital capacity breaths in 30 seconds. This is how you pre-oxygenate a person. There's one more technique of pre-oxygenation, which is the CPAP technique, in which the CPAP mask, continuous positive airway pressure mask, are applied for 5 to 10 minutes and positive airway pressure is given to the patient to pre-oxygenate. This is generally done in the cases of obesity or the patients who have basal atelectasis of the alveoli. So these are the 3 most commonly applied techniques for pre-oxygenation via using your anatomical face mask. Now, how do you actually hold the face mask? There are certain techniques to hold it. The very first technique which you all can see is the single hand technique. I hope you all remember the chin lift, the head tilt and the chin lift maneuvers. Via this head tilt and chin lift, we can make a seal of this face mask in a C and a E. This is C and the E technique, single hand technique, in which C is used to make the seal and E is used to lift the chin. This is the E which is used to lift the chin. This is the double hand technique. Same C is formed to form the seal, and this is the E which is formed to lift the chin. This is generally used in cases where the jaw is a little bigger, like in obese patients or very healthy male patients, which we have bigger jaws, such as to hold it properly. Then the technique is jaw thrust. Third is jaw thrust. If you all remember, the jaw thrust technique is generally used in cases. There are two scenes to use it. One, when you have a persistent tongue fall in spite of the using the C and the E technique. And second, especially in those patients where you are not sure about the cervical instability, you use the jaw thrust technique. In this, the jaw is lifted anteriorly and forward such that to prevent the fall of the tongue over the posterior pharyngeal wall, and the neck movements are minimal when you are giving the jaw thrust. Okay, the head tilt, chin lift are used in all cases, but not in those cases in which you have a history of trauma and you're not sure about the cervical spine stability. Whereas the jaw thrust are generally used in those cases in which cervical spine fracture or cervical spine injury is still in dilemma. Done? No cervical spine injury, head tilt, chin lift. Cervical spine injury suspicious of, jaw thrust have to be given. I hope I'm clear till now. Most common cause of obstruction during anesthesia. It is because of the loss of your muscles. Your oropharyngeal, laryngeal, your tongue muscles, they lose their tone when we give the induction agents to them or when we are giving the skeletal muscle relaxants to them. What actually happens is the tongue and the epiglottis inside, it falls back over the posterior pharyngeal wall, leading to obstruction of the airway. This is a question that is asked many times. The most common cause of obstruction under anesthesia is fall of the tongue and the epiglottis over the posterior pharyngeal wall. Okay. Now, the second airway equipment are your airway adjuncts in the form of your airways, which could be oral airways or your nasal airways. As you can see, these are your oral airways. What are these? These are your oral airways. If you can see, this oral airway has many parts. It's made up of plastic. It's quite rigid in nature. It has a tip. This is a tip which is hollow. It is hollow from inside such that it can help in suctioning. This is the area which is present on the mouth. It is the outer area. This goes inside. This is the bite block such that the patient does not bite it. And this is the flange portion which you can see the shape of this. It is similar to the shape of your tongue such that it helps in separating the tongue from the posterior pharyngeal wall and helps us in maintaining the patency of the airway. Okay. The other name for oropharyngeal airway is your Goodell's airway. The other name is Goodell's airway, and it can be found in various sizes depending upon the age of the patient, whether it is a pediatric patient or it is an adult patient. Done. When we talk about the contraindications, of course, as common sense says, if there is any oral pathology, like for example, the mouth opening is restricted, or there is a mass, there is bleeding, a lot of secretions are present, in those cases, you won't be able to insert this airway inside the mouth. So that forms the contraindications for using of the oropharyngeal airway. One more very important, not actually contraindication, but disadvantage of the use of this airway is gag reflex. Whenever you introduce this airway, there would be a gag reflex because of the touch of this part of the airway over the posterior pharyngeal wall. So the prerequisite of using the Goodell's airway is that the patient should not be conscious. Okay, the patient should not have a gag reflex, or the patient can go in spasm. It can have broncho or laryngospasm if the patient is conscious and it irritates the posterior pharyngeal wall of the patient. Talking about the Goodell's airway, the first thing when we do about the Goodell's airway is we select the correct size of the Goodell's airway. Okay. Now, how do you measure the size of the Goodell's airway? This is how you measure the size of the Goodell's airway. The central incisors till the angle of the mandible. This is the size of the Goodell's airway. Second could be, in some cases, the option is from the angle of the lips to the external auditory meatus. Even that is used to select the size of the Goodell's airway. I repeat, from the central incisors, upper central incisors to the angle of the mandible, or the angle of the lips to the external auditory meatus. This is how you calculate or you decide upon the correct size. Then first you have selected the correct size, then you select the position of the patient. Generally for the insertion of Goodell's airway, yes, many a times you have to move the neck and you have to give a head extension or the lower cervical spine flexion for the successful insertion of the Goodell's airway. Second is the maneuver. How do you actually insert this airway? How do you insert it? Always this airway is inserted upside down. Please remember this. This airway is inserted upside down. First, this is how the curve of the airway goes. That is, this side, your tip is going to point towards the hard palate. Okay. The tip of the Goodell's airway, this tip. This is the tip. This tip is going to point towards the towards the hard palate. Like this it goes. This is the flange. This is the bite block part, or this is the part which is going to be outside, and this goes like this. When this goes and a little resistance comes, it touches the posterior pharyngeal wall. At that point, it is turned 180 degree. Can you see it? We inserted it like this, and when a resistance came, we rotated it to 180 degrees such that now this body of the airway has taken the shape of your tongue. This body has taken the shape of the tongue and it has separated the tongue from the posterior pharyngeal wall. I hope you all can appreciate it. And this part is now outside the mouth and this is inside. And this has separated your two parts. This is the oropharyngeal airway. The uses of oropharyngeal airway, other than that it helps in maintaining the patency of the airway, it can also help that in mechanically ventilated patients, in ICU setting, we generally use this airway such that the patients do not bite the endotracheal tube. And secondly, in seizure patients also, sometimes we use this airway such as to prevent the biting of the tongue. Yes, this airway can be used for suctioning purpose also because it's hollow from inside and can help in oral suctionings. Second way come is nasopharyngeal airway. See, the main difference between the oropharyngeal and the nasopharyngeal airway is the material from which it is made. The oropharyngeal airway, I told you, it's made up of rigid plastic, whereas the nasopharyngeal airway are made up of soft silicone. It is made up of soft silicone. Now, as I've told you that oropharyngeal airways cannot be inserted in patients who are conscious or awake because it's going to irritate and gag reflex is going to come. Now, this is in contradiction to what is nasopharyngeal airway. The best part of NPA is that you can use nasopharyngeal airway in awake patients also because it is very well tolerated. You can use NPA in awake patients. You have to understand this because this is how the case scenarios come. As soon as we finish the airway, I'll be coming to those two case scenarios, which will help you to differentiate when the oropharyngeal airway has to be used and when your nasopharyngeal airway can be used. So the nasopharyngeal airway, this is the type of nasopharyngeal airways. These are your nasopharyngeal airways. As you can see, they are also present in various sizes. Now, sometimes there is some confusion between the shape of the nasopharyngeal airway. This is how your nasopharyngeal airway is going to look like. And your uncuffed ET tubes. I'll be showing you the uncuffed ET tubes, but please remember the uncuffed ET tubes have markings on it, whereas and markings plus a connector which is connected to the ET tube, whereas your nasopharyngeal airways don't have any connectors, they don't have any markings on it, okay, and they are made up of silicon, whereas your uncuffed ET tubes are made up of polyvinyl chloride, that is, they are PVC tubes. When we talk about the nasopharyngeal airways, one question that is generally asked is the contraindications of the use of NPA. Always remember, as practitioners, as physicians, you always have to know when to not use a thing. Many a times we know the indications, but what is important is the contraindications when you don't have to insert that thing into the nose. When? First, basilar skull fractures. In patients who have basilar skull fractures, kindly don't insert your nasopharyngeal airway because this is going to lead to CSF rhinorrhea and even your NPA can migrate into your brain. Second, if you have any nasal mass, maybe a polyp, maybe a hematoma, or any obstruction or a major DNS is present or a turbinate is there, in those cases, you cannot insert your nasopharyngeal airway. Third, coagulopathies. In patients who are very prone to bleeding, kindly don't insert a NPA because this is a highly vascular structure. Your nose is a highly vascular structure and thus it can lead to epistaxis. And lastly, if we have any active infection of the nose, because this can propagate the bacteremias. Thus, we don't use NPA in those cases. Now, for nasopharyngeal airway also, we have to select the correct size of the nasopharyngeal airway, which is from the LNSI to the tragus. In oropharyngeal airway, this was from the central incisor to your angle of the mandible. In the nose nasopharyngeal airway, it is from your LNSI to your external auditory meatus or your tragus. This is how you select the correct size of your NPA. Now, how do you insert it? The best way to insert it, the first is, it does not require much manipulation of your neck in contrast to your oropharyngeal airway. Second, you have to lubricate the NPA with a water lubricant like KY jelly before you introduce it. Now, how do you introduce it? This is the NPA. It has a bevel. Okay. Please remember the bevel has to face the septum and thus you introduce your airway first and then you have to rotate the airway by 180 degree. Thus, it will help in maintaining the patency of the airway by moving the tongue from the posterior pharyngeal wall. Generally, the questions are not asked upon how do you insert it. The most important questions about nasopharyngeal airway that are asked are about the material it is made up of, in which cases you can use it, in which cases you cannot use your nasopharyngeal airway, and what could be the possible complications when you use your nasopharyngeal airway. I repeat, the maneuver of it using it, keep the bevel towards the nasal septum, introduce the nasopharyngeal airway. When you find the resistance, rotate the nasopharyngeal airway to 180 degrees such that it is now going to get inserted between the tongue and the posterior pharyngeal wall. This is your nasopharyngeal airway. Okay. This is the nasopharyngeal airway. The disadvantages of using the nasopharyngeal airways are that it can lead to bleeding or epistaxis, or it can form a foci of infection. Done. But the advantage of using nasopharyngeal airway, the biggest advantage is that it can be used in awake patients also, unlike your oropharyngeal airway. The other uses of nasopharyngeal airway are that it helps in guiding the fiber optic insertion. Whenever we are doing a fiber optic intubation, which will coming to the fiber scope pretty soon, but if you've seen in your OTs, the fiber optic intubation needs the dilation of your nostrils, and nasopharyngeal airways help in the dilation of the nostrils. Plus, it can also guide in the insertion of your nasogastric tubes. Coming over to the differences quite fast. Without gag reflex, oropharyngeal airway cannot be inserted. It leads to gag reflex. Thus, it can be used only in unconscious patients or in the patients who are highly sedated and not awake. So what the case scenario comes actually like is, for example, a 50-year-old woman with BMI of 36 kg per meter square has been posted for laparoscopic cholecystectomy. After induction, we were not able to ventilate the patient well. Okay, we gave her head tilt, a chin lift, a jaw thrust, but still we were not able to ventilate the patient, and the patient was desaturating. So what could be the next step to do? The next step to maintain the patency of the airway is that in such a patient, after the introduction, that after we have already induced the patient with the induction agent, now we can use your oropharyngeal airway to maintain the patency of the airway. Done. So we have induced the patient. The patient is no longer conscious. The gag reflex has been blunted. Now you can use your OPA. Done. The second case scenario comes. After extubation, the patient was conscious. He was able to lift his leg. He was able to move the limbs, but still highly sedated, and there was a tongue fall, a persistent tongue fall, which was not allowing the patient to maintain the saturation. Now, in this case, where the patient is conscious, the limb movements have already come, which means that gag reflex will be present. In such cases, the airway of choice in order to maintain the patency is your nasopharyngeal airways, because the patient is conscious. Done. Oropharyngeal airway, oral suctioning can be done. Then it has a better mask fit. I've already told you it is used after the induction. So if you're not able to ventilate the patient, insert the oropharyngeal airway and over that keep your anatomical face mask and then ventilate the patient. It also is easier to insert and less traumatic. The chances of bleeding are quite less in comparison to the nasopharyngeal airways. Then the nasopharyngeal airways ka contraindication, which is very important for you all to understand. Plus, one more application of the nasopharyngeal airway is important. That is to apply CPAP in syndromic children. Nasopharyngeal airway are used like in Pierre-Robinson syndrome. This question had been asked twice. That nasopharyngeal airway can be used in providing CPAP to the kids of Pierre-Robinson syndrome. Done. Plus, they can be used in those cases in which oropharyngeal airway cannot be inserted, like oral trauma or restricted mouth opening. In those cases, in oromaxillofacial surgery cases in which the nasal patency is proper, in those cases, MPA is preferred because generally the mouth opening is restricted. When we talk about the airways, they help in decreasing the work of breathing during spontaneous breathing using face mask. When I talked to you about the face mask, I told you that face mask lead to increase in the work of breathing. Whereas when we introduce the airways along with the face mask, they will help in decreasing the work of breathing. Moving forwards to laryngoscope, I hope you'll be able to identify the laryngoscopes. Generally, the question which are image based in this is depending upon the blade. Yeah, depending upon which kind of blade is present. If a curved blade you can see, it is a Macintosh laryngoscope. Macintosh is generally used in adults, okay? And if it is a straight blade, it is the Miller's laryngoscope. It is generally used in pediatric cases, okay? There is one more kind of laryngoscope which may be present, in which you have a curved blade only, but you have a lever along with it. You have a lever and the tip of the blade is flexible. You can move the tip of the blade. This is the McCoy's. This is this McCoy, which is generally used in epiglottis, which are quite big epiglottis and very difficult to lift epiglottis. Okay, so we have three kinds of laryngoscopes: Macintosh, curved blade; Miller, straight blade; McCoy with a lever and a flexi tip. Other than that, yes, these days you have video laryngoscopes also, which have optical fibers in them, and you are able to actually visualize the whole of the airway on the screen or the monitor. Those are your video laryngoscopes. Now, coming over to the conventional laryngoscopes, you have a handle to hold. Generally, when you are intubating the patient, the handle is there on the left hand. We hold the handle in our left hand. This is something which is asked. The handle is held in the left hand. You have this hook or the electrical current, which is the electrical circuit, which is completed such that this bulb which is present, it lights. Okay, this is the bulb which is present. You have the horizontal flange. This is the portion of flange. This is the spatula in which your tongue rests. Because when you're doing your conventional laryngoscopy, you have to swipe away the tongue such that the epiglottis is visible. So the part of the laryngoscope on which your tongue rests is known as the spatula. Done? This is the tip. And this height is known as the web or the vertical step. This height is known as the web. Okay, so you have a handle, you have a hook, you have a flange, a spatula, a web, and a tip. These are your conventional laryngoscope parts. Where do you use your laryngoscopes? To view the larynx, that is your direct laryngoscopy along with the intubation. It also helps in gastric tube insertion, in foreign body removal, and obviously in the assessment of the airway. We have two different McCoy I've already told, and Bullard, McGrath, they all are different kinds of video laryngoscopes that are present. In this picture, if it is present, I'm extremely sorry I couldn't show you the image. If I have an image which comes later on, but in generally what happens in the video laryngoscopes, you have a conventional blade. You can see a conventional blade along which this a screen will be present on which the whole airway can be visualized. Done? This is your Bullard. Now a star question. Of course, I've already told you, obviously we all have to have an edge above the others. The star question here comes is, what is the principle of the video laryngoscope? The principle of the video laryngoscope, because I anticipate that laryngoscopes conventionally have been asked a lot many times, so something new has to be given, right? And video laryngoscope are the thing of trend these days. What is the principle behind video laryngoscope is the use of complementary metal oxide semiconductors. Okay, the principle is the presence of certain semiconductors in the video laryngoscopes, the complementary metal oxide semiconductors. You have Bullard, we have McGrath, then we have CMAC or VMAC, King's Vision. These are the various types of video laryngoscopes. Now moving towards the steps of laryngoscopy or the oral intubation. Each thing is very important to know. First, the position of the laryngoscopy. The first thing you all should be knowing is the indication of intubation. The indications of intubation, if you see, is one, emergency situations like the Glasgow Coma Scale less than 8. GCS less than 8 is recommendation for intubation or maintaining the patency of the airway, because GCS less than 8, patient can aspirate. Done. GCS less than 8, then elective cases. In all the cases where positive pressure ventilation is needed, like your general anesthesia cases, then in ICUs, the respiratory failure cases or the cardiac arrest cases, they are the cases in which the intubation is required. The first step of the intubation is the making of correct positioning. You have the sniffing position, barking dog position, and also known by the name of modified Shavler's-Jackson position. This is another name for this position, modified Shavler's-Jackson position, in which you have extension at the atlanto-occipital joint and flexion at the lower cervical joint. I repeat, you have flexion at the lower cervical joints and extension at the atlanto-occipital joint. The rationale behind this is that your oral axis, pharyngeal axis, and laryngeal axis, all of them have to come in the same straight line. You have to align the three axes: the oral axis, pharyngeal axis, and your laryngeal axis. Until like this, if there is no extension, no snuffing position, all these three axes are not aligned to each other. Thus, this position has to be maintained. The extension at the AO joint has to be around 75 to 85 degrees, whereas the flexion at the lower cervical joint has to be 25 to 35 degrees. I repeat, extension at AO joint 75 to 85 degrees, flexion at the lower cervical joints 25 to 35 degrees. Position is meant. Second, opening of the mouth. How do we open the mouth? The mouth is opened. We keep one hand over the forehead, and the second, the right hand fingers are used to open the mouth. Done. This is how you move the chin in a downward direction. One is this method. Second method which is asked is the scissoring method. For what the scissoring method is used? The scissoring method is used to open the mouth during your intubation. This is how you form a scissor and you open this mouth. Done. Now, once the mouth is opened, the laryngoscope is held in your left hand. You insert it via your angle of the mouth, the right angle of the mouth. This is the right angle of the mouth. You insert your laryngoscope. As you insert your laryngoscope, you swipe the tongue on the left and take your laryngoscope to the midline. Inserting the laryngoscope is always from the right angle of the mouth, and slowly you take your laryngoscope to the midline. You visualize your epiglottis, and now the question that is asked is where the tip of this blade is kept. The tip of the blade is kept at the vallecula. Then this is a question. The tip of the blade is kept at the vallecula, and as soon as you see the epiglottis, it is lifted. And what is the direction of your force? The direction of your force is upwards, like this. It is away from you towards the ceiling, okay, around at an angle of 45 degrees. And the force is exerted via your triceps and your deltoid. The triceps and your deltoid. These all are the questions that are asked, okay, at an angle of 45 degree away from you towards the ceiling. And third is the force has to be from your deltoid and your triceps. Your forearm has to be kept straight and you have to be around 2 to 3 centimeter away from the bed. Never be just on the edge of the bed, because you're not able to visualize or have a good view of the laryngeal structures. Always keep a little away from the edge of the bed. Done. This is how it will help you to have a binocular vision, a good binocular vision. Once the epiglottis is lifted, you have the glottic opening, and in the glottic opening, you are going to insert your endotracheal tube. I hope the seasoning method, the forehead, the hand which is kept on the forehead has to have the extension, and thus we open the mouth first. This is the ramp position. In cases of obesity, we use the ramp position such that you can see here the insertion of the laryngoscope would be very difficult, such that your sternal notch and your external auditory meatus are in the same line. Okay. In obese patients, we have a ramp position or head elevated laryngoscopic position such that an imaginary line is drawn. The external auditory meatus and the sternal notch in a supine patient are in the same line. This is again a question which is asked, what is the ramp position? Done. And where it is used in the cases of obesity. This is what you are going to visualize. This is again an image which is asked. This is the image of the laryngeal structures which you are going to visualize during your direct laryngoscopy. If you see carefully, these are your shiny white vocal cords. Okay, these are the vocal cords. This is the base of the tongue. This area is nothing but the base of the tongue. This is the epiglottis which is lifted. Done. These are the vestibular folds. These are your vocal cords. Okay, what are these? These are your vocal cords, and here are your cartilages, your cuneiform, your corniculate, and your arytenoid cartilages. These are your arytenoid cartilages. Done. You have to be able to identify the base of the tongue. This is the epiglottis. This is your vocal cords, and these are your cartilages, your laryngeal cartilages which are present. Now the question which is asked is, see, trauma. Trauma during laryngoscopy. The most common area which gets traumatized during your laryngoscopy is upper central incisors. I repeat, upper central incisors are the area which gets traumatized mostly during laryngoscopy. Done. During intubation, what can you traumatize us? During intubation, the trauma is most common at the laryngeal cartilages, out of which articulate cartilages are the most common. The articulate cartilages suffer from trauma during intubation, and upper central incisors during your laryngoscopy technique. That is why it is always told, whenever you're practicing laryngoscoping during your internship days, kindly don't form a liver at your teeth. Okay, your force always has to be against you towards the ceiling, and don't put in extra force on the teeth. Now, once you have intubated, I've told you the glottis is open, you are able to visualize the glottis, and now you're going to introduce your endotracheal tube. What are you going to introduce is endotracheal tube. Now the sequence is, once the endotracheal tube is inserted, done. Now what you're going to do? You have to fill the endotracheal tube's pilot balloon with air The sequence is fill it with air first. After filling it with air, the sequence is actually asked. The first is you have inserted the tube. Second is you fill air in the tube. That is the cuff of the endotracheal tube is inflated. Second is then you check. Check is 5-point auscultation is done. What you do is 5-point auscultation is done after the insertion of the endotracheal tube. Where do you actually see these 5 points? One is your gastric, two the upper part of your anterior thorax, and two at the axilla. 5-point auscultation is done. Then you can confirm whether the endotracheal tube is in situ or it is not in situ. How do you confirm? There are various methods of confirmation. For example, mist formation. Second could be the chest movements. If you're giving positive pressure ventilation and your endotracheal tube is in situ, your chest, bilateral chest movement will be visible. Then third is auscultation. You can auscultate. Last is your capnography, your EtCO2 graph. I hope you remember the capnography graph, EtCO2 versus your time graph. But at least 3 waves have to come in order to confirm that you are in the right place. Please remember, 3 capnographic waves are compulsory to come to differentiate between the esophageal intubations and your tracheal intubation. Please go and revise the capnographic graph if you have forgotten it. So this is your capnograph. Capnograph, it is the most common method which is used to check the confirmation of the endotracheal tube is in situ or not. The most common. But what is the most sensitive? The most sensitive method is direct visualization of the passage of the endotracheal tube in the glottic opening. That you are actually seeing the endotracheal tube being introduced into the glottic opening. That is the most sensitive method. Then comes the gold standard method. The gold standard is your fiber optic. Yeah, this is something new. First, the gold standard was your capnography, but nowadays for single lumen tubes as well as for double lumen tubes, the gold standard is your fiber optic bronchoscopy. That fiber optic can be used to check whether the single lumen tube is in situ or not. Done. 3 types of question comes. The most sensitive method for the confirmation of endotracheal tube, that is this, the direct visualization. The most commonly used method, that is your EtCO2. Or in case the fiber optic is not in the options, then even the gold standard method of confirmation is your EtCO2. Done. But if there is options are both fiber optic also and EtCO2, then the gold standard is your fiber optic. You have to take the fiber optic option. After checking, after the confirmation, then you are going to secure your tube. Then you are going to secure your tube. One important thing that I've forgotten to tell you is that checking does not only include to see whether the patient's whether your tube is in trachea or not, but also this includes to rule out endobronchial intubation. Endobronchial intubation means that your ET tube has gone into one bronchus. Generally, it goes to the right bronchus. I've already explained to you first. So, we have to check that it is not gone endobronchial. To check whether it is endobronchial or not, the first can be used as the movement of the chest. Right will move, left is not going to move. Then auscultation, you can auscultate and check. Then secondly, generally much changes don't come in your EtCO2 graph. So generally the checking method for endobronchial intubation is either auscultation or your movement of the chest. That is how you check for your endobronchial intubation. Now laryngoscopy. The laryngoscopy is a highly stressful technique. It leads to a stress response generated in the body because When the laryngoscope comes in contact with the laryngeal and the pharyngeal receptors, all these receptors get stimulated and lead to release of the catecholamine surge, a sympathetic stimulation in the body, which could be quite hazardous when it comes to elderly, cardiac, or certain patients who have comorbidities associated with it, because it can lead to an increase in the blood pressure and the heart rate up to 25% of the baseline. So in order to decrease that sympathetic stimulation, there are certain drugs which can be given before the laryngoscopy, and this question is generally asked, that which are the drugs which can be given to decrease the stress response. First, we can deepen the plane of anesthesia. One, the induction agent has been given. Second, the inhalation agents can also be opened. Second, opioids like your fentanyl or remifentanil can be used. Dextromethorphan, clonidine, the alpha-2 agonist can be used. Xylocard, that is the 2% lignocaine without preservative, can be used. Beta blockers like esmolol, metoprolol, your calcium channel blockers, then your vasodilators like nitroprusides or nitroglycerin can be used. Then your magnesium sulfate again can be used to blunt this stress response. In order to decrease the stress response, always remember the appropriate time of performance of the laryngoscopy along with intubation is 11 to 15 seconds. 15 seconds is the max in which you have to insert the endotracheal tube. This is the apt time of performance of laryngoscopy along with intubation in order to decrease the stress response. Done. Moving now to the third equipment, which is your endotracheal tubes. The parts. What is an endotracheal tube? Artificial airway, and it is a definitive artificial airway. Please remember this. By definitive, we mean that this is going to prevent your aspiration. It is not only going to give the positive pressure ventilation to the patient, but also it is going to prevent the aspiration. What are the parts of ET tube when we talk about? The parts of ET tube are very, very important to know. Let's start. This is the distal part, the patient end, and this is the machine end, which is the proximal part. It has a connector. It is a universal connector of 15 mm, which is connected to a 22 mm connector from the breathing circuit. Okay, if you remember the scavenging circuit, a quick recapitulation. In scavenging circuit, it was different from the normal breathing circuits of R, because it was 19 and 30 mm circuits we had, whereas the normal circuits we have 15 and 22 mm. From the connector, then we have this tube. It is made up of polyvinyl chloride. This tube has various markings on it, which is going to tell us the depth of insertion. This is going to tell us the depth of the insertion with maximum number towards the machine end. Done. Then over this tube we have, an internal diameter which is written. I hope you all can see it. Then we have the outer diameter that is written. We have the company's name. It is also written whether it is oral or nasal. Many a times it is written here. Then it is written it is cannot be used for the second time. It is disposable kind of tube. These are the markings, the length markings in centimeters. Done. Then you have a radio opaque line here. You have a radio opaque line such that this tube can be visualized on a X-ray. You have a radio opaque line in the endotracheal tube. Then you have a vocal cord guide. Here generally you have two black markings, and when you are inserting your endotracheal tube in situ, till what you have to insert, this is that black marking. You have to stop once this black mark enters your glottis. This is also asked. The radio opaque line is asked. The connector size is asked. The material from which the ET tube is formed, it is made, is asked. And till what you are going to enter the glottis, till the black marking, that is your vocal cord guide, is asked. Then you have a cuff system. The cuff system includes your one-way valve. This is the spring-loaded one-way valve. This is the pilot balloon. This is your inflation tube. And this is some part of the inflation tube is also inside this tube, which leads to this cuff. This is your cuff. Majorly, this cuff is of low pressure, high volume. We'll come over to the different types of cuff. This cuff is low pressure, high volume cuff. Then you have a bevel, which is this cut margin. This is the bevel. This bevel is generally facing the left side. This is a question that is asked. Even the type of the cuff is asked. Bevel is generally left side. Then you have an extra opening here, which is the Murphy's eye. The Murphy eye is present as an alternative path to ventilation in case the tip gets obstructed because of certain blood or secretions. Then you can have a patency or an alternate ventilation through the Murphy's eye. The name of this tube is endotracheal tube with Murphy eye, and there are certain tubes which don't have this Murphy eye which is present, and those tubes are known as the Meggle's tube. Again, this is asked. A lot of questions is asked from the endotracheal tubes. The Meggle's tube are the tube which don't have Murphy eye. I hope I'm clear. This tube is present in the form of a curve, and the radius of this curve is, this is known as the Meggle's curve. The radius of this curve is 140 millimeters. The radius of this curve is 140 millimeters. Done? When you see this tube we are going to insert into our body, into a body of a human being, such that these tubes are tested. Okay, when we see these tubes, all these tubes have a number written over it. Some F or tested number is written. Then there are certain numbers like CE numbers which you can see on the back cover of these tubes. These tubes say that these tubes are inert to the human tissues. Okay, because the testing of these tubes material is done in the rabbit's intestine. Yeah, it is done in the rabbit's intestine. The testing has been done already, and they have been found to be safe. And when this toxicity level has been checked, only then these are used for insertion into the human body. Done? So these checking of the tubes is always done before it is inserted. And these are some F numbers which are given on the back of the endotracheal tubes. Endotracheal tube decreases the dead space. They decrease the dead space except in preterm neonates. This exception is asked, and the reason for the exception is asked. The reason for the exception is that in preterm neonates, the length of the tube is more. See, the length of the tube which is used for the preterm neonates is more than required. That is why the dead space sometimes increases in preterm neonates. Of course, there is one solution to it. We can cut the length of the tube in certain cases. Okay. The resistance of the tube. The tube works on the principle of Hagen-Poiseuille's law. The Hagen-Poiseuille's law says that the resistance is directly proportional to the length. More is the length, more is the resistance, and inversely proportional to the fourth power of the radius. Lesser is the radius, more is the resistance. This is what Hagen-Poiseuille's law states. Most of the tubes these days that we used are made up of polyvinyl chloride. Older tubes were made up of red rubber. We'll come to the difference between red rubber and PVC tubes. We have an internal diameter or outer diameter. The bevel is generally left-sided. Done. Why it is left-sided is asked. So why it is left-sided is because when we talk about the vocal cord opening, the bevel at the left side helps in better visualization of the laryngeal structure rather than bevel on the right side. That is why the bevel cut is cut on the left side, such that the introduction of the tube becomes easier and you have a wider vision of your laryngeal structures. Done. Second, Murphy eye, and the Murphy eye, without Murphy eye we have Megal's tube. Coming over to the tube sizes. When we talk about the tube size, what we talk about is the internal diameter. Please remember this. The tube size is decided according to the internal diameter, because internal diameter is something that is going to decide about the resistance and the work of breathing that the tube is going to give. Okay, it is the internal diameter on which the resistance which will be given by the tube is dependent upon. In general, in adult females, we use 7 to 7.5 mm tube. In adult males, we use 7.5 to 8 mm tube. The maximum diameter tube that is available to us is 10 mm. Now, this is again a question. Then age. See, when we talk about how can you actually calculate the size of the tube which is required, it is the age which has been recognized as the most reliable indicator of the appropriate tracheal tube size. Done. When we talk about the internal diameter, especially in pediatric cases, it is used age in years upon 4 plus 4 in more than 6 years. And when it is less than 6 years, we have age upon 4 plus 3.5. Generally, then till 12 years of age, we use this formula. After that, we have like adult females will use 6.5 or 7, or in adult males, we'll have 7.5 to 8 mm tubes. In pediatric patients less than 6 years, we use age upon 4 plus 3.5, less than 6 years, more than 6 years, age upon 4 plus 4 mm internal diameter. You have to remember this formula. Done. This formula is also known by the name of Pellington's formula. In preterms, the tube size is 2.5 to 3 mm. Terms 3 to 3.5 mm. 2.5 is the minimum radius tube that we have. Okay, the minimum diameter tube that we have is 2.5 mm. 1 year, 3.5 to 4 mm tube is used. Yes, you have to revise it again and again in order to memorize which size of tube is used in which age group. One other surrogate marker for the tube size is to use the anteroposterior diameter of the distal phalanx of the fifth finger, generally used in pediatric cases. It helps in calculation of the outer diameter of the ET tube. This is what is asked. I know these are the tricky questions which comes in the NEET PG or NIN CET. The outer diameter of the ET tube, the surrogate marker for the same is your anteroposterior diameter of the distal phalanx of the fifth finger, generally used in the pediatric cases. Coming to the depth of the insertion, how much you have to insert the tube and where you have to secure the tube at the anterior incisor. As a whole sole, the depth of insertion is given by the formula of 3 times the internal diameter of the tube. For example, we are using a 7 mm tube. So the tube has to be fixed at the 21 centimeters. Okay, the tube has to be fixed at 21 centimeters such that 21 centimeters is visible at the angle of the mouth. When we talk about the nasal intubation, in the oral intubation, we have 21 centimeter. To that, we'll add 5 more centimeters. That will be the depth of insertion for the nasal intubation. Then, in pediatric cases, we can have the length in centimeter of the ET insertion like age upon 2 plus 12. I repeat, age upon 2 plus 12. Done. In those pediatric cases where length cannot be taken but height is taken, it is height in centimeters upon 2 plus 5. These are two different formulas that have been used. In some cases, we have height in centimeter upon 2 plus 5, and their length is taken in centimeters, it is h upon 2 plus 12. The most commonly asked is this one, h upon 2 plus 12. So kindly remember this. One you have to remember is h upon 4 plus 4 or 3.5 depending upon less than 6 or more than 6. Other you have to remember the depth of insertion in pediatric cases, that is h upon 2 plus 12 centimeters in length. Done. Then you have rule of 789. I know there is a lot to memorize, a lot to learn, but revisions are required for the same because airway equipments form a very major chunk of your NEET PG MCQs. The rule of 789 is 1 kg, 7 centimeter you have to they have the depth of insertion, 2 kg, 8, 3 kg, 9. There are two other formulas which can be used in very small children, that are your neonates or your infants, in which you have nasal to crown heel length in 2.21 or crown heel length in 2.16 plus 2.5 centimeter. Practically, I understand it's very difficult to memorize, but please remember this depth of insertion is 3 times your ED diameter, and this formula h upon 2 plus 12 plus the rule of 7, 8, 9. We were talking about the cuff system. In the cuff system, we have a spring-loaded one-way valve, a pilot balloon. This pilot balloon is filled with air. How much air? Around 3 to 5 ml, such that the intra-cuff pressure has to be maintained at 25 to 35 centimeter water. Must to know. This is must to know. The intra-cuff pressure which has to be maintained is 25 to 35 centimeters of water. See, when we talk about the cuff system, there are generally two types of cuff system. We have low volume, high pressure. We have high volume, low pressure. In our modern day ET tubes, these PVC tubes have high volume, low pressure, which means that the area of contact is very high. More the area, less is the pressure. Like they both are inversely related to each other. More the area, lesser is the pressure. Thus, there are lesser chances that there would be tracheal mucosa injury because the pressure that is exerted on the tracheal wall is less. Done. So, the chances of ischemia, injury, stenosis are all less in this cuff system of low pressure, high volume. But it's high volume. So, the area of contact has to be more. More is the area of contact, there are more chances of sore throat in this cuff system. First. Second, because of this main increase in the volume or increase in the area of the contact of the cuff, there is kinking which is present in the cuffs. So micro aspiration chances are also more in this cuff system. The seal is not 100% in low pressure, high volume because of the presence of these grooves, because the area of the contact is very high. Vice versa, contrast is your other cuff system, that is your low volume, high pressure. Because of the high pressure, the chances of tracheal mucosal injury is very high, but the seal that is formed is very good, and thus there are no chances of leaks or aspiration which are present in such a tube. This is present in your PVC tubes, and this cuff system is present in your red rubber tubes and one special tube, that are your laser tubes. Laser tubes are special tubes which are resistant to fire, generally used in the laser surgeries. This cuff system is used in the laser tubes because there is no leak. And if you all remember from our anesthesia machine class, oxygen is a combustible substance, not combustible, it's a supporter of combustion. So we don't want any leak of oxygen to be present. And thus in laser tubes, we use high pressure, low volume cuff system. Done. Then we have the uses of the cuff system which are asked. In this, first is to prevent the leak, to prevent the aspiration. What this cuff system does not do is, it does not prevent the dislodgement of your endotracheal tube. Please remember this. Cuff system is not going to prevent the dislodgement. Done? One thing which I forgot in the disadvantages of the commonly used cuff system other than sore throat and microaspiration is because this volume, the high volume cuff is quite big cuff. So when you are introducing this tube also, this tube decreases the visibility during intubation because of the presence of this floppy cuff. Red rubber tubes, please see the picture, the image. This is the red rubber tubes. Nowadays it is not used. These tubes were reusable tubes. It did not have any radio opaque line, thus it could not have been seen on the x-rays. Done. The cuff system was high pressure low volume cuff system, which increases the chances of tracheal ischemia. Vice versa is your PVC tube. Moving forward to the cuff system, more or less, I think we have already covered system. Sorry. Then moving forward to the conformation. Conformation I've already told, it's the flexible bronchoscopy. Then we have the bronchial intubation, and how to detect the bronchial intubation was via your auscultation and your chest movements. This was the method for auscultations. Then we have the change in depth. Please remember one thing, that when we were talking about the insertion of the endotracheal tube, the insertion can change. The endotracheal tube depth can change with when the neck movements are there. Neck flexion or change in the position of the patient, the laparoscopic surgeries or Trendelenburg surgeries. In all these cases, the endotracheal tube depth of insertion can change, and this is something which is also asked because generally the case scenario is given, like for example in a laparoscopic cholecystectomy, pneumoperitoneum has been created. So now what next complication can occur? So the complication that occur is your endotracheal tube can get dislodged, it can get misplaced, and the depth of insertion of the endotracheal tube can change. Done? Tube tip position. Generally the best position for the tube tip is 3 to 4 centimeter above your carina. Your carina is at the level of T4. Done. 3 to 4 centimeter above T4 is the best position for the endotracheal tube tip. When the patient has a flexed, it is 3 centimeter, neutral 5 centimeter, extended, then it is 7 centimeter away from the carina. This is the best position. The carina is at the level of T4. The tip of the tube has to be at the level of T4. Just remember this. Indications for the endotracheal intubation, I think you are cleared with it. During your endotracheal intubation, there are certain maneuvers which are asked. Like the case comes that you were intubating the patient, but you were not able to clearly visualize your glottic opening. Then which is the maneuver which can be used, and on what cartilage this maneuver is used? This is most important. The maneuver that is used is your burp. You give a force, not you actually, the assistant gives a force, that is the backward, upward and rightward pressure is given on the thyroid cartilage. I repeat, the pressure is backwards, upwards and rightward pressures given on the thyroid cartilage. This is very different from your Selix maneuver or your rapid sequence intubation, where the pressure is given on the cricoid cartilage. The burp is given on the thyroid cartilage. Done? Depth of insertion, I've already told you the formula of it. All that black marking, the vocal cord guide which is present on endotracheal tube, or third, in case that black marking is absent, then you have to insert your tube around 2.5 centimeter beyond your glottic opening. I repeat, 2.5 centimeter beyond the glottic opening. How much air you have to fill? 3 to 5 ml. Confirmation, you can do it. And most injured part is upper central incisor. Nasal intubation. See, the indications for nasal intubation is that if there is any problem in the oral, like you have an oromaxillofacial surgery, you cannot intubate the patient orally. Done. Then for if there is any mass in it or you have trismus, the restricted mouth openings are there. In all these cases, you prefer a nasal intubation. The advantage of nasal intubation is that the patient is not going to bite the tube. It is more easy to secure and it is well tolerated than your oral intubations. Done. The disadvantages of nasal intubation is that generally in nasal intubation we use small diameter tubes. And as I've already told, according to Hagen-Poiseuille's law, lesser is the diameter, more is the resistance, and thus the work of breathing increases. Then the intubation via nasal intubation takes a little longer. You can have epistaxis, bacteremia, sinusitis, and otitis media as complications of nasal intubation. The contraindications of nasal intubation are almost similar to what we had studied for NPA, basilar skull fractures, coagulopathy, or any anatomical or mechanical impediment in the insertion of the nasal tubes. The complications, the stress response, then the failure of intubation. The intubation can fail. You can have esophageal intubations which are detected via your EtCO2. Okay. The EtCO2 is used to detect your esophageal intubation. Then endobronchial intubation, I already told, your chest movements or your auscultation. The other could be, which was asked also, increase in the peak airway pressures. The peak inspiratory pressures increase if we have only a single-sided lung which is being ventilated. I repeat, in endobronchial intubations, we have increase in the peak inspiratory pressures. Done. Then we can have accidental extubations, we can have obstruction of the tube. Post-operative, the most common complication of your endotracheal tube insertion is your sore throat. Even this is a question. The most common complication of endotracheal tube is sore throat. Then during your insertion of endotracheal tube, you can injure the recurrent laryngeal nerve. Okay. And post intubation, you can have ischemia of the trachea leading to stenosis. Then there are various kinds of endotracheal tube. Importance is the images. Okay. You have Oxford tracheal tube. This is the L-shaped tube. A L-shaped tube which is non-kinkable. You have flexometallic armored tube. Armored because it has a metallic wire which is embedded inside this tube, or a nylon wire which is embedded in the wall of this tube, such that this tube is flexometallic and does not kink, and thus this can be used. This is a tube of choice in head and neck surgeries, or in the surgeries where the position of the patient has to be changed, like lateral, prone. In those cases, the preferred tube is flexometallic tube. Done. For the insertion of flexometallic tube, you need a stillet. No radio opaque line is needed because you have that metal wire. Done. One time only this has been asked, that who introduced this flexometallic tube. It was by Dr. Franz Kessler. Dr. Franz Kessler introduced this flexometallic tubes, which are also known as armored tubes. They are flexible, non-kinkable. Double lumen tubes. Identification of the double lumen tube is, it has two cuff. One is the bronchial cuff, which is blue in color. This is bronchial cuff. You have double lumen. Can you see the two lumens? And then you have two cuff inflation tube systems also. This is double lumen tube, which is used to isolate the lung anatomically and physiologically for one lung ventilation, like in case of cardiothoracic surgeries, pneumonectomies, bronchiectasis surgeries, abscess drainage, or lung resection surgeries like in carcinomas, etc. The confirmation is asked of DLT. It is via your fiber optic bronchoscopy. How do you confirm for it? It is via fiber optic bronchoscopy. This is your double lumen tube. This is basically to ventilate just one lung, and one lung gets completely without air, and you can actually perform surgery on that lung. Laser endotracheal tubes. Again, this picture is asked. This generally this one is asked. Yeah, this is asked. The laser resistant endotracheal tubes. These are the tubes which are PVC or red rubber tubes, and they have two layers on it. One is the metallic foil layer that protects from the laser light, and other is a Teflon non-reflective layer over it. Done. The special part of this tube is that the cuff is filled with blue colored granules with water or saline. I repeat, the cuff is filled with blue dye granules with water or saline. This is methylene blue. This helps that if the cuff bursts, so there are two. First, it indicates, you can see that some blue color is coming out of the mouth. So you know that the cuff has bursted. You have to be very careful now. Second, water can be used to extinguish the fire if it has arisen from the tube. Done. So you have a special tube in which you have two foils, two layers. One metallic foil, other is your Teflon or non-reflective layer, and the cuff of this tube is filled with blue color. Methylene blue dye is used. This is the cuff filled with blue dye, which acts as an indicator, and also it helps in extinguishing of the fire. Already told you the cuff in this tube is high pressure, low volume, such that to give a perfect seal so that we don't have a leak of the supporter of the combustion, that is your oxygen. Then comes the ring Ardier Elwin tube, RAE tube. These are preformed curved tube which help to provide good surgical access to the oronasal surgeries like cleft lip and palate. You have a north pole and a south pole. This is the south pole tube, and this is a north pole tube. The north pole tube gets fixed on the forehead and the south pole tube gets fixed on the chin. So the south pole helps in your cleft palate surgeries. The north pole tube is going to help in your lower jaw surgeries, your mandible surgeries, your thyroid surgeries. Done, such that the surgeon has an easy access. The problem with these tubes are you cannot suction to these tubes and their length cannot be manipulated because you have a preformed curved in these tubes. The work of breathing and resistance is always higher in such tubes. Then you have microlaryngeal tubes. The beauty of the microlaryngeal tubes is that the diameter of this tube is very small. These are generally used for a better exposure or surgical access to the larynx itself. For example, you have vocal cord hematomas or vocal cord granulomas, or a biopsy has to be taken from the vocal cords. In those cases, you use these microlaryngeal tubes. Diameter is small, but the length is equal to that of the any other PVC tube. This is made up of a special type of PVC, that is the ivory PVC, in order to reduce trauma. I hope it is clear. You have uncuffed tubes or microcuff tubes which were used in the pediatric cases. These are the tubes which don't have a cuff system. Generally, it was said that uncuffed tubes should be used in pediatric cases less than 8 years of age in order to avoid tracheal stenosis, because the narrowest part of the pediatric airway is subglottic. Please remember, the narrowest part in adults is the glottic opening. The narrowest part in adults is the glottic opening, whereas when we talk about pediatric cases, it is the subglottic area which is the narrowest. Done. But these days it has been seen that even cuffed tubes can be used in pediatric cases, in which we have special micro cuff pediatric tubes which are coming these days. Because uncuffed tubes, the problem is the chances of aspiration are very high. Then in ICUs, this photo comes with this tube that we can see. This is your endotracheal tube with suction. This is the endotracheal tube with suction, generally used in the cases of ICUs. We have a subglottic port here through which you can suction all the secretions around the cuff. Okay, the micro aspirations that take place can be prevented through this. Now, talking about the characteristics of uncuffed tube or the cuffed tubes. The uncuffed tube, the advantages are the internal diameter is more, so resistance is lesser. You have less work of breathing, and the chances of the blockage by secretions are also less, and you can easily suction it, and it helps in preventing the trauma to the subglottic region. But yes, the disadvantages are that you have a leak of the air, and the chances of aspiration are more in uncuffed tube in comparison to your cuffed tubes. Fiber optics. Fiber scopes are a newer version which are used of laryngoscopes in order to aid in intubation in cases of anticipated difficult intubations. In anticipated difficult intubations, what we use is fiber optics, or in cases in which you have nil mouth opening, like restricted mouth opening, fracture of the mandible, orofacial pan fractures, panfacial traumas, or submucosal fibrosis patients in which you have restricted mouth opening. In those cases, nasal intubation can be done via your fiber scopes. Fiber scopes are nothing but flexible, this is flexible body fiber scopes which have integrated optical glass fibers which work on the principle of total internal reflection in order to form a image of the larynx which can be visible on a screen. A camera is attached on the eyepiece. Yes, this eyepiece can also be used to visualize, but it can be attached to a camera which is further attached to a full-fledged screen, and this can be used for teaching purpose also. This flexometallic tube can be inserted and it has an image forming. It has optical glass fibers for the carrying of the light source, and thus an image is formed and we are able to visualize the larynx directly on the screen, with the help of which we are intubating the patient. The thing that you all have to remember is that the use comes in the difficult intubation. Done. Second thing is what is present in this working channel. In this working channel, we have a Bowden cable system. This is the working channel. In this working channel, you have a suction. I'll just show you the parts of the fiber scope. This is your fiber scope. This is the light source. This is where from light comes. This is where the camera attaches on the eyepiece. This is the tip of the scope that is going to go inside the airway. These are the side ports which can be used to introduce certain drugs, or this can be used for your suction purposes or the installation of your local anesthetics or for the cleaning purpose. Then you have a suction port also. You have a control lever here to control the movements of the tip of the scope. This control lever and the tip of the scope is joined together with the help of certain cables. which are inside this fiber scope. Done. And lastly, you have this insertion cord. The diameter of this fiber scope is around 2.8 mm to 5.9 mm. This is the range of the diameter of the fiber scope. Done. And then you have the field view of the fiber scope. Not very important for you all to know. Just understand the fiber optic intubation is used in the cases of anticipated difficult intubations or in cases where you have restricted mouth opening. The size of the endotracheal tube when you are talking about the fiber optic has to be 0.5 to 1 mm more than the outer diameter of your fiber optic scope. I think this is quite clear that the ET tube diameter has to be more than the diameter of your fiber scope. Lastly, coming to the management of the unanticipated difficult tracheal intubation in adults. The next part of the airway equipments, that are the supraglottic airway devices, I'll be covering it in the very next class. The management of the anticipated difficult tracheal intubation is, we have various plans when we have an unanticipated difficult tracheal intubation. That is, the first is ventilation. The face mask ventilation and tracheal intubation. The first thing is we optimize the head and the neck position. We pre-oxygenate the patient. We give adequate neuromuscular block to the patient. Then we take at least 3 plus 1 attempts. This is what you have to remember. The maximum number of the attempts which are given for intubating the patient in plan A is 3 plus 1. 3 attempts can be given by the person concerned and 1 attempt has to be given by a senior professional. But you have to be careful that in all the 3 attempts, the technique of laryngoscopy has to differ. That is, you have to either use certain adjuncts like bougie, stillet, or you can use a video laryngoscope, a McCoy blade. You can change the size of the blade or the type of the blade. Done. 3 plus 1 attempt. Then you can give burp to the patient. You can maintain the pressure over the thyroid cartilage. If intubation is successful, confirm it via your ETCO2, that's capnography. But if it fails after 3 plus 1, please change to plan B. The plan B is maintain the oxygenation, give face mask ventilation to the patient, and then insert a supraglottic airway device. That is your plan B. A second generation supraglottic airway device is recommended. Here, the maximum attempts that you can take are 3 attempts, in which we can change the device also. We can change the size of the device also. In second generation, you have a lot of supraglottic devices. You can use iGel, you can use a ProSeal, or you can use the different sizes if you are not able to successfully insert the supraglottic device. Done. Maximum attempts which can be done are 3 attempts. I repeat, the maximum attempts which are allowed are 3 attempts. If you succeed in inserting a supraglottic airway device, please stop and think, can the surgery be conducted in a supraglottic airway device? If yes, then proceed with the surgery. Second, if not, then wake the patient up. Thirdly, if you have inserted a supraglottic airway device like a fast track or intubating laryngeal mask airway, through these devices, endotracheal intubation is possible. Either intubate the trachea. Done. Or lastly, if it is a very urgent surgery, an emergency surgery is there and it has to be done, but it cannot be done into a supraglottic airway device, you are oxygenated, you have confirmed that the patient is getting ventilated, so you can buy time and do your tracheostomy. That is, your surgical intervention can be done. If you fail to insert the supraglottic airway device also, declare failure after 3 attempts. Come back to face mask ventilation. If face mask ventilation is impossible, You cannot ventilate the patient and the patient is paralyzed. Use different techniques for face mask. That's the last rescue which can be able to oxygenate the patient. You can use 2% techniques, you can use certain maneuvers, you can improve your technique. If you succeed in ventilating the patient via face mask, wake the patient up. But if you are not able to ventilate the patient also, then comes the dreadful condition or of cannot intubate, cannot oxygenate condition comes. In such a case, go for FONA, that is your front of neck access. Emergency cricothyrotomy or tracheostomy has to be done for such a patient. That is your plan D. I repeat again, plan A, after face mask ventilation, try intubating the patient 3 plus 1 attempt with different maneuvers, different sizes, different technique in all the attempts. You don't succeed, plan B, insert supraglottic airway device 3 attempts. Again, change the type or the size of the supraglottic airway device. You fail to insert a SAT. Go for face mask ventilation. That is the only rescue you have in order to oxygenate the patient. And if you are not, your plan C also fails, cannot intubate, you cannot oxygenate the patient, go for emergency front of neck access. That is your cricothyrotomies or your tracheostomy. I hope this part of the airway management and equipment is clear to you. We'll come back with the supraglottic airway devices and revision of all this part which we have covered in the next very class. Thank you.